the head of clinical services, other members of the TMC, the chairman of the hospital presentation committee, heads of departments, consultants, special guests, and distinguished ladies and gentlemen. It's a great honor for me to be chosen to be making this presentation today. As you have heard, we are talking about confidentiality and privacy, especially the aspect of balancing patient autonomy with healthcare needs. I must state that 1 hour will not be enough to tease out the nitty-gritty issues involved in privacy and confidentiality. But I was told that I have just 30 minutes. So I will see how much ground I can cover within the allotted time. This is the outline I'm going to use. I will define some key terms. Then we talk about the concept of confidentiality and privacy. Then we have a glimpse on the rights of the patient. Then we look at informed consent, and we look at ethical dilemmas and how we do the balancing. Because that's what we are talking about, balancing autonomy and healthcare needs. By way of definitions, confidentiality means non-disclosure of a patient's medical information to a third party or to an unauthorized party. So it means protection of the information provided by the patient. Privacy, on the other hand, means protection of the patient from exposure, whether physically or socially or psychologically, and preserving the secrets of the patient. What is the difference? In confidentiality, we are talking about the patient's data or information. In privacy, we are talking about the patient as a person. That the patient's secrets and privacy must be protected. Autonomy, on the other hand, is the patient's right to make informed decisions regarding his care and who has access to his information. Then, informed consent is communication between the patient and the healthcare provider, leading to agreement or permission for care, whether it's in the form of treatment or intervention or procedures. This is just the big ideal definition. I will be coming into details of this. So let's come to the concept of confidentiality. Now, everything we are discussing today, they fall under the purview of medical ethics. But we are discussing medical ethics. And medical ethics has to do with the commitment of the health provider to prioritize patients' welfare, protect his autonomy and his dignity. That's what it means. That's what ethics means. And you cannot talk of medical ethics without talking about confidentiality and privacy. It is also a component of quality care. You can never claim to provide quality care when you cannot assure confidentiality and privacy. In fact, it is part of the vision and mission of the hospital. As you are walking into this hall, you see one board there, that is the cervical board, talking about what we promise the public, our charter. And it is clearly stated in black and white. We are going to maintain confidentiality and privacy. It is a component of the Hippocratic Oath, which every medical doctor must have sworn. Before you are given license to practice as a doctor anywhere in the world, you are going to swear the Hippocratic Oath or the physician's oath. In fact, in Zamfara here, anytime we gather for our CME activity, the oldest doctor in the house will lead all the doctors to reaffirm that oath. And a text of that oath reads thus: I solemnly pledge to dedicate my life to the service of humanity, the health and well-being of my patient will be my first consideration. I will respect the autonomy and dignity of my patient. I will respect the secrets that are confided on me even after the patient has died. That is a pledge every doctor makes or must make before you are licensed to practice. And I believe the same thing will apply to other health professionals, nurses, pharmacists, as many as handle patients' data. There must be a form of code or pledge that you are going to be discreet in handling the information that will come to you. Now, if you are not a health worker, but you are a staff of FMC and you are properly employed, following due process, you must go through what we call induction. And during the induction, you are going to swear oath of secrecy. I was around this year when the new inductees, the new employees of the hospital were inducted. And on this podium, the barrister led them on a oath of secrecy. Unfortunately, I couldn't get the actual picture of that event to show you something like this. I'm showing you the one, I think, from India or somewhere else. But the barrister made all the inductees to swear that oath. And I have a text of that oath. And it says, I, put your name there, employed as, put your department, solemnly and sincerely swear that I will faithfully and honestly discharge my duties that devolve upon me by reason of my employment as so in the Federal Medical Center, so, and I will not, directly or indirectly, without due authority, communicate or reveal to any person any matter brought under my consideration or shall become known to me as whatever you are employed for. So that is the oath. Because if you are working in the hospital, one way or the other, you are going to come across secrets of the patients. And so long as you have sworn this oath, you are under oath to keep that secret. So it is something that concerns everybody that is here. Now, this concept is also part of the patient's Bill of Rights. There's a document or an act called the Patient's Bill of Rights. And what I'm showing you is the one that Nigeria has agreed to. There are many of them. Number one is that the patient must be treated with respect, irrespective of the tribe, religion, gender, sexual orientation, socioeconomic status, educational status. Every patient must be treated with respect and dignity. But we used to say that the patient is king. Every patient is king. The way you treat royalty is the way you are going to treat every patient. Then, patient has a right to relevant information, information that he needs and he demands. You should give it. He has a right to urgent intervention in case of emergencies. And he has a right to decline care. The patient can say, I don't want this type of care. He has a right to safe environment. And then look at where we are. He has a right to privacy and confidentiality. He has a right to collaborative involvement. Gone are the days when health providers, health professionals make decisions for patients and hand it over to them, and they must follow. No. Today, the patient has a say. He's a stakeholder. You must consult him and get his approval before anything. He has a right to change provider. In fact, a patient can come to hospital and request, I don't want to see this doctor. I want to see the other doctor. He can request, I want to change the team. I don't want this team managing me. I want another team. He can request, I want a second opinion. I don't trust you anymore. Let somebody else look into this matter. These are rights of the patient. And the patient has a right to timely access to service, to information. He has a right. And he has a right to transparent billing. When you give a bill, you must know the context. What did you bill him for? What are the charges? That's why under Sabicom we publish price lists everywhere. When you got to pay, this is the cost. So that when you get your bill, you know what the expenses you have incurred and what you are paying for. These are bills of rights and they are other under ethics. Now, let me talk about patient's privacy. Let me go into detail. Privacy, as I said, is respecting the privacy of a patient. That somebody is a patient in the hospital does not mean that what is private is not private anymore, or what is personal is not personal anymore. So when you are treating that patient, remember that he's a person and he has secrets. There are different layers of privacy. We have physical privacy, which has to do with the space where you see the patient. You have to make sure there is privacy. And what is private should be kept private, including the private part. You know, I think last month or so, when we were doing our inspection round, we entered a ward and a nurse was doing dressing for a patient, a surgical wound. And that wound was on the pubic area. And that dressing was happening in the open ward, about 6 beds in that cubicle, all the beds occupied. And you know, there was no effort to screen that bed, to cover that patient, and that dressing was going on. When I walk in, I say, foul, this is wrong. It's violation of privacy. And they told me there's no screen. It's only one screen in the ward, and it is being used by another patient. And that's why a patient was unduly exposed, an adult man. That is wrong. If you are conducting examination or doing procedure, remember privacy. Provide privacy. So that is space. Number two is informational privacy. Even when you are getting the information, there should be privacy. For instance, when we take history, there are some personal questions we ask, private things we ask. We are asking those questions because we believe they are useful for us, either to make diagnosis or to plan the management. But those information are for our consumption, for our ears only. Now consider a situation you are taking history from a patient in the clinic. There's another patient in that same room. There's a patient relative in that same room. Or even the patient's relative is there. When you are getting this sensitive personal information, that is violation of privacy, information privacy. Because what he's telling you is not meant for those people. It's for you. There's no reason why they should overhear what he's telling you. So that is informational privacy, the data of the patient. When you are collecting it and after you have collected it, it should only be for the people that are concerned. Even another health worker that is not part of the team must not have the information of the patient. I cannot walk into a surgical ward and start going through their records. It's not acceptable. But let me share an experience with you. In 2017, I traveled to US. I visited my in-law. She was working in a hospital. At that period, her status was observational. That is, she's not yet a full-fledged staff. They call it observation, something like probation. But they do put her on shift. She comes to work, run shift. So it happens that her husband was using the same hospital as his health provider. So one night he was on night duty. She went and logged into the record of the husband. In the morning, it was detected that there was unauthorized access. And they began the investigation. And she was going from panel to panel. In fact, the system detected that I think between 20 to seconds to 30 seconds, there was a violation. Eventually, she wriggled out. But now, let me tell you, that is the husband. But for the fact that the husband did not give consent, the medical team did not give consent for her to log into that information, it was considered violation of privacy. God helped her, she escaped. Okay? So even members of a family, if they are not entitled, they are not entitled. If the patient did not give the consent for you to disclose his information to somebody, you shouldn't do that. Then we come to decisional privacy, where a patient has a right to make choices based on his conviction, either religion or cultural. We put it under our mission that we are going to provide services that are culturally acceptable. So it is what the patient considers acceptable that he is going to accept. That is privacy. He has a right to do that. And then we have associational privacy, whereby a patient can decide who he wants to be around in terms of the relatives. I think last month or so, I brought a patient, psychiatric patient, and eventually they admitted her. And she told me that she doesn't want to see any visitors. Nobody should come and visit her. She's a member of our church. And she said, I don't want any church member. I said, sign, nobody will come. And I told the nurses, nobody should come. The patient said she doesn't want to see anybody. That is privacy. Sometimes you may be taking a history from a wife, and the wife will say, excuse my husband. Before I give the information you are asking, let my husband leave. You should be allowed. Even a child, a child can say, excuse my parents. You should be allowed. Because if you didn't do that, you won't get the information you are looking for. So a patient has a right to decide who should hear the information, to whom you should disclose. That is associational privacy. Now we come to informed consent. Informed consent is a process in which a healthcare provider educates a patient about the risks, the benefits, and alternatives of a given procedure or intervention. We talk about patient will make informed consent. So you have to give the information. But patients are not experts. You know better than them, but that will not give you a right to take decision on their behalf. So what you do is that you give them the minimal information they need so that they can make informed decisions. And they will give their permission. That's the consent. They give their approval for you to do what you plan to do, either procedure, examination, investigation, or any other procedure. You have to approve and consent. That is what we mean by informed consent. There are different types of it. We have explicit. Explicit means it is clearly stated. In fact, usually it is written. In those days when we use the paper folder, case folder, if you go to the back, there's a consent form. If a patient is going for procedure, some things are written. You read it for the patient, interpret it, and you understand it, then he will sign. That is explicit, it's clear. But sometimes before some operation, they say, where is the consent form? Where is the consent form? Has the patient given consent? Either the patient or the person taking decision on behalf of the patient, he has to consent. Then there's implied. This one may not be written, but for the fact that the patient has agreed. For instance, you are doing a research and you give out questionnaires to people. Anybody that accepts the questionnaire and fills the form, it implies that he consented to be part of the survey or investigation. So that is implied consent. Then we have the one we call opt-in. Opt-in is the right of the patient to participate in the procedure. Let's put it this way: a patient comes for something, to take a service. He has something in mind. But there is another service you think will be beneficial. So you give information to the patients that this one is also available. For instance, here in this department, there's a family planning clinic. So women come for family planning. They know what they want, family planning. But then you say there is screening for cervical cancer. It's available, it's free. So when they come, you tell them there is screening for cancer. And you tell them the benefits. When you finish, you go and sit down. Then those who are interested will come for it. That is opt-in. They have opted in. Then we have opt-out. Opt-out is when you are going to provide a service for people, except those who don't want it. Like the same department here, ANC. Any woman that comes for booking for the first time, we must know the HIV status. We must screen her. So when they come, you give information that there's going to be screening for HIV, all of you. But if somebody says, I'm only here for ANC, no screening, the person has opted out. You should be allowed. What do? Give her the ANC, and you don't force her to do this HIV. Now, the criteria for informed consent, number one, there should be clarity. You must give clear information, and you make sure the patient understands what you have explained. Number two, comprehension. That's what I just said. Clarity, you must be clear. Then comprehension, find out if the patient, if you're on the same page with the patient. Then competence. The person to give consent must be competent, both legally and mentally. The patient is of age and is of sound mind. There are people we call minors. Children don't give consent. Parents give consent on their behalf. Except what we call emancipated minor. There are people we call emancipated minor. So those one can give consent without the parents. Then it should be question free. You don't force anybody to give consent. You don't intimidate. You don't manipulate. It should be voluntary and it should be unbiased. Now, I have a picture on the board. It's a story I want to tell. In the early days when we started HIV program in this hospital, this child came to our clinic. He was around age 1 year old, and he has advanced HIV disease, WHO clinical stage 4, what we used to call pediatric AIDS in those days. This was the period when the ART came out. We call it highly active ART, HART. So the picture one is when we had contact with that child. That's picture one. Then we commenced HART. After 5 months, we repeated the picture. That's picture 2. Then after 1 year on treatment, that is picture 3. In those days, we used to do what we call quarterly review meeting. States of Zamfara, Sokoto, and Kebbi, we come together and we do like monitoring and evaluation. We tell our stories. So I represented FMC in one of the meetings at Green Cape, and I presented this picture as our success story. And the IP said this is wonderful, that it is going to be used in the project report. It's going to reach the IPs, the country office, even the funders, PEPFAR, in those days. Then they asked me, do you have consent for this picture? And lo and behold, I didn't have consent. So I have to invite the mother, and I showed her. She knew when I was taking I took the picture with my phone in my consulting room. If you look at the background, they are the same background. So my consulting room at home site. So I told her, see the pictures, and we want to use these pictures. It may appear in international publication. And she said, go ahead. That's why I'm showing this picture without any guilty conscience, because this is the first picture for which I have informed consent. The mother said, use the picture to tell the story of the success of highly active antiretroviral therapy. So before you use any patient's picture, make sure you have consent. That's the message there. Are there exceptions to the rule? Are there situations where confidentiality and informed consent may not be guaranteed? The answer is yes. Number one, when life is in danger. If you are tracking a patient and the patient is telling you he has made plan to kill somebody, if he has even bought the gun and other things you use, you are going to disclose or without permission. You must notify the authorities. That's exception. Or a patient wants you to help him to commit crime. He say, please prescribe this mind-altering drug of abuse. You know, some drug you can't buy from pharmacy without doctor's prescription. And patient say, I want to use it to do something terrible. Write it for me. You are not going to cooperate, and you must report. Or when there's infectious disease outbreak, you know this patient has something that is epidemic prone or pandemic prone, you must notify the authorities. You don't keep confidentiality. Or when the court orders, sometimes a court may order you to appear and talk about the patient. In that case, you are going to disclose some information and breach confidentiality, and you are not liable. Or when you suspect a child abuse, or when you are seeking for second opinion, you may have to violate. Now we come to ethical dilemma. That's something that every doctor must meet one day. The day when patient's autonomy conflicts with the best medical judgment. You know, you want to maintain autonomy, patients have made a choice, but you know that this choice is not the best. Now let me paint a picture. In this hospital, we have women that are HIV positive and they are on drugs and their husbands are not aware. We have men, they have been on HIV drugs for 10, 15 years. The wives are not aware. We cannot disclose to their partners. We don't have the right to violate autonomy. It is when the patient is ready to disclose that he will do it. But let me ask you, assuming you have a patient like that, a young lady on HIV drugs, and then she starts dating somebody that she wants to marry, and that somebody is your younger brother, and you ask her, have you told your fiance? She said, I will never tell you. So, what do? There is autonomy, patient's right to disclose, and there is an issue. Okay?
I would act as a brother there, brother.
Or let's say O and G.
Look, the marriage is out.
Yes. Dr. Ibrahim has a patient from FCT. She has the ruptured ectopic and lost that tube. After 6 months, he ruptured the other one and lost that one. And then she's engaged to marry and is your best friend. And you ask her, have you told the man? He said, I will never tell you. So that is where autonomy conflicts with clinical judgment. What do? That's a dilemma. So how do you balance the act? Balance it. So there's what we call pillars of medical ethics. There are 4 things you must always consider. Number 1 is the autonomy we have talked about. Then there's what we call beneficence. Beneficence means doing good. You have to do good, both to the patient, to other people, to the system, and to the community. Then there's also non-maleficence. That is, do no harm. And then you have justice. You have to be just. So these are the things you have to balance and find the middle ground. So I come to conclude, and my conclusion is with a question: why does it matter? Why are we discussing this? Number 1, for professionalism. This is what makes us professional. The fact that you can keep secret is what makes you a professional. Any doctor that cannot keep secret is not professional. Any nurse that cannot keep secret is not professional. Let me tell you, my wife is a health worker, but there are information about some patients I will never share with her, and she will never know. 2 days ago, we had sent forward for HCF, Christian Healthcare Christian Fellowship, and one of the retirees was an admin staff, and he said, I have some secrets of FMC that are going to die with me because I swore oath of secrecy. That is professionalism. Number 2, litigation. Most of the medical legal issues that come up has to do with what I have discussed, violation. You can lose your job because of this. You can lose your license. You can even lose your freedom. You can go to jail. You can go to jail because of violation. And it's also what consumes mutual trust. You see, the patients on daily basis share their secrets or sensitive personal information to the healthcare providers. Such information should be protected in order to ensure trust and confidence in the system. There are so many things patients tell us, and they're telling us because they trust us. In fact, this that they've not told their husband, they will tell the doctor. Things that they will never share with any human being, they will share with you. We must maintain the trust so that they will continue to trust the system. And of course, it's a human right. Patient's right is a human right. Confidentiality, privacy is a human right. I think that is the end of the story. Thank you very much.